Mahmood is going to talk about stenting, right?
Yep. So the next topic is indications and outcome of stenting. All right, here we go. All right. So these are my disclosures. And so indications, obviously, for venous stenting, patient has to be symptomatic. And they have central venous obstruction, not peripheral. The stents in the peripheral veins so far have not done well in the current generation of stents. And these include things like May-Thurner syndrome, central venous obstruction in patients with chronic venous insufficiency, patients with post-thrombotic syndrome, and patients with pelvic venous disorders in presence of central venous obstructions. Special considerations such as renal vein compression, chronic IVC occlusions, adolescents and pediatric age group, and splanchnic venous disorders, these all need different discussions. They all need their own topics, so we're not going to talk about them. With respect to the extremities, specifically lower extremities, the symptoms of obstruction are pain, cramps, heaviness, paresthesias, pruritus. And then signs would be, we all recognize edema, skin induration, pigmentation, redness, so on and so forth. And the advanced obstruction would be, in advanced cases, it would have venous ulcerations. There are some non-extremity signs and symptoms. Patients with pelvic venous disorders. These could be due to venous outflow obstruction, not always the refluxing veins in the system. Pelvic pain, pressure, varicosities. These are the symptoms we used to call pelvic venous congestion in women. Limb edema, heaviness, varicosities can occur in the setting of venous outflow obstructions. Dyspareunia and infertility, dyspareunia in women, infertility in men, renal vein compression we talked about, hematuria, pelvic venous disorders, and then the SVC syndrome. We won't talk about those. The question is, what constitutes obstruction in the venous segment? Now, the old literature suggests a pressure gradient of 2 to 3 millimeter in a recumbent patient is enough to be considered physiologically significant. The problem is that measuring 2 to 3 venous millimeter pressure gradient is within the area of measurement of most of our equipment. So that's very difficult to do. So therefore, what about the 50% reduction in the cross-sectional area as compared to the reference vein? This is sort of the established guideline that most people use. The problem is that it's not validated. Now, presence of collaterals, a lot of us use that, rely on it. If there are collaterals, maybe the obstruction is significant. If they're not, it's not. The problem is most patients that we test are recumbent, and so it's hard to know. So presence or absence of collaterals can be therefore misleading, and the 50% reduction or the threshold has not been validated. So we don't really have a good way to know what a significant obstruction is. You could look at this and say, yeah, this looks significant, of course. In a symptomatic patient, when you see something like this is significant. So this needs to be stented, obviously, and the patient is relieved. Also note that the collaterals and the reflux into the internal iliac vein is now relieved, and the flow is all antegrade rather than going through collaterals. Cross-sectional imaging with CT and MR can be very helpful. Duplex ultrasound, of course, venography, and intravascular ultrasound. Venography is probably the least sensitive of these. Now, the IVUS literature, unfortunately, is very scant, not a whole lot. There are no rigorous comparative studies or correlative studies that we can correlate what we find on IVUS with symptoms. However, I think Virtus trials, when we have the one-year data, would probably start providing some information on correlative studies between IVUS, cross-sectional imaging, and venography in this set of symptomatic patients. So we're very excited that once that data is available, we finally will have some good data on these imaging studies and correlation to symptoms. Advantages of IVUS, everybody knows: detection of residual clot, improved visualization of vein lumen, of course, distinction between intraluminal pathologies versus compression problems, and ability for real-time measurement of area stenosis. These are some of the advantages of the IVUS. Now, Venous stent applications, obviously, in patients with chronic venous insufficiency, example of which was shown by Dr. Kalori. About 10 to 30% of patients with chronic venous insufficiency do have outflow obstruction. 30% is probably generous, so it's probably about maybe 10 to 20% of these patients have really outflow obstruction that contributes to the patient's symptoms. Conjunction with DVT interventions, bigger studies, larger studies, multi-center studies have shown about half the patients will require a stenting in these patients who are treated with deep vein thrombosis. And, of course, patients with pelvic venous disorders such as pelvic congestion syndrome. Examples, 79-year-old female complaining of edema, tender bulging vaginal varices. They were position dependent. The relevant history was the left saphenous vein was closed 6 weeks prior to this study, and patient has had DVTs in the past. So as you can see on the CT scan, multiple varices, vulvar varices and pelvic varices anteriorly. These are the symptomatic ones. And when you do the venogram, a typical post-thrombotic femoral vein and occluded common femoral and iliac venous system. And these are the these are not multiple veins. These are recanalized veins and with synechia inside these post-thrombotic veins that are damaged. And here are these varicosities that patient complaining about. Of course, but this is recanalized in angioplasty. Angioplasty in these settings never works. You have to almost always stent them in non-dialysis patients, by the way. And here's post-stenting. As you can see, stent needs to be extended to the point where the inflow is good. If not, the whole thing would thrombose fairly quickly. And this is post with the outflow. Now, patient placed on anticoagulation, and these are standard sort of treatments post-venous stenting. What is the data? Now, the Raju's group, Raju and Negland, have the largest single-center studies in the literature. Unfortunately, they're mostly all retrospective, and there are always problems with these, with interpreting these types of single-center retrospective studies. They're not all, the results are not always generalizable. However, we do have better studies. This is a very small study of randomized 50 iliac obstruction lesions, and they defined obstruction as greater than 50%. And they all have chronic venous disease, CEEP of 3 to 6, with a visual analog score of greater than 5. So these patients were symptomatic. And they randomized them to stent plus or stent plus medical therapy versus medical therapy alone. Assessment was blinded, and the primary outcome was a change in the VAS score and the ulcer healing. So this is what they saw. Interesting. And if you look at the patients who had stent and medical therapy versus those who got medical therapy, the pain level was significantly improved. Ulcer healing, they did not test, but the VCSS score, again, significantly improved, and the quality of life also statistically significant, showing that in those patients who do have true venous outflow obstruction and chronic venous insufficiency, that actually relieving obstruction helps in patient clinical outcome. Now, this is a meta-analysis of the studies in the literature. We broke patients into non-thrombotic, acute thrombotic, and chronic post-thrombotics, and looked at the data on the stenting, and those are the number of stents. The procedural complications were very low, and the clinical, the efficacy was very high. So venous stenting, generally not very difficult unless you're dealing with chronically occluded long segment veins. Those can be challenging. And the primary patency up to 5 years, as you can see, very respectable. And the best are in non-thrombotic patients, and the worst were chronic post-thrombotic patients. A lot of it had to do with the fact that these patients with chronic occluded venous segments have poor inflows, they have long segments, so there are multiple reasons why the patency in those patients are not as good. And the secondary patency, obviously, very nice and very respectable. So outcome, clinical outcome in patients, again in this, as you can see, in acute thrombotics, results were very good, most of it because we got rid of the clot also. The non-thrombotic, slightly worse, and the chronic post-thrombotic, still about 60 to 70% of these patients significantly improved in their symptoms. So in conclusion, does any symptomatic central venous obstruction need a stent? I don't think we have proven it. It's too early to make such a blanket statement at this time, but it is likely that most patients with symptomatic central venous obstruction will benefit from stent placement. The question is, what is a obstruction? And that remains to be determined. Thank you.